Hello and good evening, everyone. Hope you can hear me loud and clear. And welcome back to my IVF Fences and our IVF webinar. Hope you had a nice weekend and are ready to learn a bit more on low ovarian reserve. And tonight we will talk about different cases. Again, we have our special guest with us tonight, Dr. Anna Blázquez. You can see her right here. Hello, Dr. Anna. How are you feeling? Great to have you back. This is your first webinar with us, so welcome and thank you for joining us tonight. How are you tonight?
Fine. Thank you very much for inviting me to this webinar. I hope it will be nice for all of us.
Sure, I have no doubt. I know that you will present some case stories. There are like 5 case stories that you will go through and talk about what has been done to achieve pregnancy. So I'm already looking forward to this. And as always, remember that there will be time for your questions. So remember, all you need to do is type those questions in the chat section, and Dr. Anna will definitely help you out. And let me just mention that Dr. Anna, she is the head of medical research and specialist in reproductive assisted reproduction, and of course, she's talking to us from Eugin Clinic, which is located in beautiful Barcelona. So I'm glad that you are staying a little bit longer at work to help us out here and, of course, discuss this important topic indeed. And thank you, everyone, for joining us tonight. It's wonderful to see some familiar names already, and I'm sure you have lots of questions. So as always, remember, you can type the questions during the presentation, but afterwards it's also possible. So don't hesitate, okay? This will be your time. We are here definitely for you. And let me just add that myivfences.com, we are part of European Fertility Society. And if you have been following us, you know that there are over 350 webinars already so far, and this autumn we have started our special project, which is focused on success stories on various doctors present various real life cases, and it's great to be here with you. So don't hesitate, as I've mentioned, to type the questions. And now I guess we can go ahead with the presentation. And let's have a look what Dr. Anna has prepared for us, okay? Yeah. Go ahead.
Okay, great. So thank you, Caroline, for this presentation. I'm Dr. Anna Blázquez. I work as a gynecologist here in Eugin, Barcelona. And as you know, I will talk today about low ovarian reserve, and I will show you 5 different cases. Let me say also that I should apologize for my English because it's far from being perfect, as you will see in a while. Let's start with the explanation of what is a low or a poor ovarian reserve. The definition is a decline in the follicular pool of the ovary. We talk about follicles. The follicle, it's like the balloon that has the oocyte, the egg inside. When the specialists, we do a scan, an ultrasound, what we measure, it's those little black rounds are the follicles that contain each follicle, one egg. So we usually talk indistinctively of follicles, oocytes, or eggs. The main cause for a low or poor ovarian reserve is the age of a patient. So we know that when we are born, we have around 1 million oocytes, but each month we ovulate only from one single egg, but there are many others that start the process of getting mature, and we lose them naturally. So that's why each month we lose an amount of follicles, and finally we reach the menopause. But not only the age is a cause of low ovarian reserve, there are some other issues, some other pathologies that can decrease the ovarian reserve of a woman. For example, endometriosis, infections, ovarian surgery, or also idiopathic causes. That means that we don't know the cause. The problem with the poor ovarian reserve is that it implies a decrease. It decreases the chances of getting pregnant. And usually patients with low or poor ovarian reserve need medical help to get pregnant. How can we diagnose a low ovarian reserve? So we will need a test to measure the ovarian reserve of a patient. There are some indirect signs of a low ovarian reserve, as it can be the shortening of the menstrual cycle. There's usually, we have a lot of patients who tell us that they used to have cycles of around 28, 30 days, and in the last month, their cycle have shortened to 24, 25 days. That's a sign, that could be a sign of low ovarian reserve, but obviously not all the short cycles mean that the ovarian reserve is decreasing. And then there's a test that it was used a lot in the past, that it's the basal FSH. FSH is a hormone that should be measured at the beginning of the cycle, and when FSH is high, usually above 10, 15 units, that could mean that the ovarian reserve is low. But the two tests that we are using nowadays are the anti-Mullerian hormone. This is a hormone that can be measured at any point of the cycle, and it should be done by a blood test. And then the antral follicle count. That's the count that we, the gynecologist or the specialist, do by a scan, by ultrasound. We measure how many follicles a patient has in each ovary, and we count them. With both tests, the lower the anti-Mullerian hormone or the lower the antral follicle count, the lower the ovarian reserve of the patient. The problem is that there's not a universally criteria to say from which point this ovarian reserve is normal or it's low, and it also depends on the age of the patient. But in 2011, the European Society of Human Reproduction and Endocrinology published the Bologna criteria to try to diagnose patients with low ovarian reserve. They say that if a patient fulfills two of these three criteria, it can be diagnosed of poor ovarian reserve. And the criteria are having 40 years or older, or having a risk factor for poor ovarian reserve, for example, ovarian surgery, having had a previous ovarian stimulation, and as a result of this stimulation, having had only 3 or less follicles, or having an abnormal ovarian reserve test, as it could be an antral follicle count lower than 7 or an anti-Mullerian hormone lower than usually 1. And what can we do for this patient? Well, the main issue with this patient is the time. We know that every month we lose ovarian reserve, so we should try to get those patients pregnant as soon as possible. So that's why we usually skip the first treatment, that is intrauterine insemination. We know that intrauterine insemination is a very good treatment for specific patients, but the success rates are lower than with IVF cycles. And in poor ovarian reserve patients, as we want to get the pregnancy as soon as possible, we usually start with IVF cycles. And the gold standard with this patient is to do an IVF cycle with a high dose of gonadotropins for the ovarian stimulation. There are different kinds of gonadotropins, but the important thing is to start with high doses. Then we have some other strategies. For example, the modified natural cycle. In these cycles, the patient starts without any kind of stimulation, and once she naturally has selected one egg to ovulate, we give her a mild stimulation to ensure that we will have at least one egg, and then we do the ovum pickup to get only one oocyte. That's why we keep this strategy for patients that we know that they have a really low ovarian reserve, and that even doing one strategy or another one, we will only get one egg. Then we have another strategy, that's the androgen supplementation. That's a little controversial because there's not scientific evidence yet that with giving androgen we can increase the ovarian reserve, but in some cases we can try. Androgen is a male hormone that actually all women, we have androgen in our blood, but the doses in women are low. And in those patients, we can try giving a mild stimulation of testosterone to try to improve the ovarian response to the stimulation. And then regarding IVF cycles, we can give to the patient pre-treatment with oral contraceptive or estrogen to try to synchronize all the follicles. Because sometimes, even that the patient has a low ovarian reserve of around 4 or 5 follicles, we start with the stimulation and only 1 or 2 of these follicles grow. With this pre-treatment, what we try is that all the follicles grow at the same time, so we will be able to program the ovum pickup to get all of them. And then there's the last step that we can always use, that it's oocyte donation. It's obvious that oocyte donation is the most effective treatment with this patient because, as I have mentioned, they are usually old patients, that they are usually 40 or above. And with oocyte donation, what we have is two advantages. We have usually more quantity of eggs, but also the quality of those eggs is better because donors, at least here in Spain, are young patients. They are between 18 and 34 years old, and that's what gives us better quality and more chances of getting pregnant. So let's start with the cases. The first case, maybe it's the most successful case. It's a case of a patient who came to the clinic when she was 43 years with her couple after 11 years of trying of getting pregnant. She had never been pregnant, and when we evaluate her ovarian reserve, we saw that she had 4 follicles, 2 in the right ovary and 2 in the left one, and her anti-Mullerian hormone was low, 0.8. So we suggest her to start with an IVF cycle due to the age, the years of infertility, and the ovarian reserve. And we did a cycle with a high dose of menopur, that is a gonadotropin, that means 300 units per day. I know that in some clinics, they give even higher doses of gonadotropins, up to 450 units, but it has been widely shown scientifically that there's no changes of ovarian response giving more than 300 units per day. So usually here, the higher dose that we give is 300 units. So in this patient, after giving this stimulation, we get, after the ovum pickup, 3 oocytes. One of these oocytes was mature. We did the insemination with the ICSI technique with her partner's sperm. We had 1 embryo that was freshly transferred on day 3, and she was pregnant and delivered a healthy girl at 36 weeks. The baby was a little premature, but this is normal because with the age we know that the rates of prematurity is a little increased, but it's now a healthy and a happy baby. The second case, it's a younger patient. She had, actually, when she came to the clinic, she had 36 years. She was single and she wanted to be a single mother. So as she was not infertile, we started with intrauterine insemination with sperm of a donor. But after 5 unsuccessful failed cycles, then we suggest her to go through an IVF cycle. She was then 37, and we reevaluate her ovarian reserve then, and we count that she had 6 follicles in the ovaries. We started with an IVF cycle, giving her a high dose of menopur, and but after the ovum pickup, we only get 2 oocytes. Only 1 was mature. We did the ICSI technique. We had 1 embryo that was transferred on day 3 without success. So for a second attempt of IVF, we thought that something could be done to improve the ovarian reserve. As we counted, she had 6 follicles, but we only get 2 eggs after the ovum pickup. So we tried with transdermal testosterone during 5 days, the first 5 days of the ovarian stimulation, again with high doses of menopur. In this attempt, we get 8 oocytes, which 8 of them were mature. We did the ICSI technique. We had 4 embryos. 2 of them were transferred fleshly at the first attempt without success. and the 2 others were freezed and then thawed and transferred without, again, success. Fortunately, the patient was not tired yet, and she did a third attempt. We repeated the same strategy as in the second attempt because the results were much better than in the first one, with testosterone, high doses of menopur, and we had, again, 8 oocytes, 6 mature eggs. We did the ICSI with the sperm of the donor. We had three embryos, and after the first transfer of 2 embryos on day 3, she got pregnant, and she delivered a girl at term. The third case is the youngest of all the 5 cases. She was a 33 years patient who came to the clinic with her couple after 2 years of trying of being pregnant without success. We evaluate her ovarian reserve, and we saw that she had 4 follicles with an anti-Mullerian hormone of 1.2. So we suggest them to start with IVF cycles and skip intrauterine insemination. At the first attempt, we started with, again, high dose of gonadotropins, and we saw during the ovarian stimulation that only 1 follicle was growing. So before the ovum pickup, we canceled the cycle because we thought that in this patient who had 4 follicles in the antral follicle count, maybe we could have better response of the ovaries. In the second attempt, we tried with a pretreatment with estrogens orally 1 week before starting the stimulation. Then we again did a stimulation with high dose of menopur, but again, only 1 follicle was growing. But this was the second attempt. We decided to continue. We did the ovum pickup. We get 1 mature egg that was fertilized with her partner's sperm, and we did a single embryo transfer on day 3 without success. So for the third attempt, we suggest them to try with a modified natural cycle, as we knew that only 1 oocyte was possible to achieve in this specific patient. So she started the cycle without any kind of stimulation. We did the follicular controls, and once we saw that 1 follicle reached 40 millimeters, we start with a more mild stimulation. We did again the ovum pickup. We get only 1 follicle, that's what we expected. We did a single embryo transfer, but in this attempt, we were successful, and she had a boy. The fourth case, it's a 41-year-old patient who came again with her couple after a secondary infertility of 1 year. She already had 1 daughter of 13 years old. Obviously, when she was 28, it was easy to get pregnant, but once she had 41, after 1 year without success, they came to the clinic, and we evaluate her ovarian reserve. We saw that her antral follicle count was 6, and her anti-Mullerian hormone was 1. We tried a first IVF cycle with the standard protocol in those cases, that's high doses of gonadotropins, and we saw that only 1 follicle was growing. So again, we canceled before the ovum pickup, as we thought that a better result could be achieved in this patient. With the second attempt, we gave her oral estrogens, there are pills, 1 week before starting the stimulation. Then again, we did a stimulation with high doses of menopur, but in this occasion, we had 5 oocytes, 3 were mature, 2 were correctly fertilized, and we did a double embryo transfer on day 3, and she got pregnant and delivered a healthy boy. And the last case, it's the case with the older patient. She came to the clinic when she was 44 with her couple. They together have had a miscarriage 3 years ago. This is something that it's not infrequent, as she was 41 when she had the miscarriage, and we know that miscarriages at the beginning of the pregnancy are something. It's something that it's not infrequent, but especially with age, because the older the patient, the higher the chances of having a miscarriage. And when we evaluate her ovarian reserve, we saw that it was really low. She had only 2 follicles in the ovaries, and her anti-Mullerian hormone level was 0.5. Besides, she told us that she had already done 2 IVF cycles in her country because she was French. The first one with high doses of stimulation, she only get 2 follicles, one mature. They did a single embryo transfer without success. And on the second attempt with the same protocol, they only get one mature egg, but there was a fertilization failure, so no embryo was available to be transferred. So at this point, we suggest her to do an oocyte donation treatment because this was the best treatment for them without doubt. She underwent an endometrial preparation with transdermal estrogen and vaginal progesterone, and we select a donor for her. We obtained from the donor 8 oocytes, 7 were mature, and after the fecundation with her partner's sperm, we had 5 embryos, and we leave those embryos until the blastocyst stage, until day 5 in the incubator. We finally had 4 blastocyst embryos. We transferred only 1 embryo because it was an embryo on day 5 with oocytes from a donor, and she is now still pregnant. So these have been the cases. It's true that it's not always as successful as in these cases. It's difficult in patients with low ovarian reserve to achieve a pregnancy. We always have the option of ovarian oocyte donation, but I want to recall that in patients with low ovarian reserve, especially if they are young, we can try many strategies to achieve a pregnancy. So now, if you want to start with the questions, I will be happy to answer as much as I can.
Sure. Thank you so much, Dr. Anna. Thank you so much for bringing those 5 cases. Definitely, I believe that there are lots of patients that can relate to any of those. So thank you for taking us step by step what was done to get that successful outcome. And of course, you are very right. It's time for the questions. As you can see, some of the questions are right here. Some of people are typing. So of course, remember, use this time and with Dr. Anna, and of course, ask as many questions you would like, and I'm sure she'll be happy to help you out. And let's get going, okay? Let's have a look at the very first question here. I have low ovarian reserve and have prescribed DHEA 25 milligrams. I recently had a polyp removed and had a history of cysts. Will DHEA increase my risk of these issues reoccurring, and does this benefit outweigh the risk, in your opinion? Thank you for your question.
Actually, no, the HAE won't increase the risk for cyst or polyp, endometrial polyp, but we don't usually recommend it to our patients because there's no scientific benefit of taking this medication to increase the ovarian reserve or even to increase the quality of the eggs. But it actually won't make you any harm. So if you want to take it, when patients take it because someone or their gynecologists have recommended, we agree, but we don't think that it could increase substantially the results. So asking maybe the second question, you can take it without worries.
Okay, thank you so much for the first question, and of course for your help with that. I do believe it has been helpful. Okay, let's have a look. More questions are coming in. Next one is from Olga. With low ovarian reserve, do you recommend day 2, 3 embryo transfer or day 5?
Okay, that's a good question, and it depends a lot on the clinic because I know that there are clinics that only do transfers on day 5, but as you have seen in my cases, we have done a lot of day 2, 3 transfer, and that's because we know that between day 2 or 3 until day 5, an embryo inside an incubator maybe cannot survive. And it cannot survive because an incubator, it's not the natural environment of an embryo, that's the uterus. So we know that day 5, it's a better stage to transfer the embryos because it's the implantation rate is higher. But if we have we have a risk from day 2 until day 5 to lose some embryos that maybe in a uterus can give us a very healthy and happy baby. So what we do is we decide if we take the risk to arrive until day 5, depending on the number of embryos that we have. If we have a lot of embryos, if we have around 4 embryos or more, we take the risk to arrive until day 5, because maybe we will only get one at the end, but this embryo has a high potential of a pregnancy. But if we have usually 3 or 4 embryos or a lower number, then we prefer to be conservative and we transfer the embryos on day 2, 3, because we don't want to lose a healthy embryo during the way. Usually the biologists are the ones that give us the recommendation depending on the number of embryos and on the quality of those embryos. And our cutoff, if we have 3 very good quality embryos, we can take the risk of arriving until day 5. If it's a lower quality or lower number of embryos, we prefer to do the transfer on day 2, 3. Okay.
Yeah, sorry, I'm right here, of course. Thank you so much indeed for yet another question and a thorough answer. Let's have a look. Okay. Olga has added one more question, so let me go straight to that one and we will go back to the previous one. All the clinical cases that you presented with patient X, the transfer was done with 3-day embryo, right? Is there any specific reason? You kind of answered that, but anything else you can add?
No, it's because it's this reason. We are maybe a little conservative, but it's true that maybe the patient will have more failed transfers. That it's something that I know that it's difficult to cope with, because a negative result is something difficult to cope with. But we prefer not to lose any embryo, any good embryo in the lab. So that's why if we had 3 embryos or less, we always do the transfer on day 3.
Of course. Thanks a lot indeed. And our patient already said that it was answered. So thanks a lot, of course, for adding that as well. Right, you can see here. Thank you. Okay, let's have a look. Another question from Lenka we have with a little bit of details. I am 38, lost my pregnancy at my 33 for severe preeclampsia, now having AMH 0.6, FSH 11, normal 10. I got gonal high doses, no follicles, cancelled cycle, second cycle high doses of menopur 500 and LH, but no follicles. Last was the soft one with the clomiphene. I had 3 follicles, but no oocytes. Do you think that I should try testosterone on estrogen, or donation is best option for me?
Okay, the best option in your case is egg donation. That's true, because in the best scenario possible, if maybe you can try with some strategy with you, maybe a modified natural cycle or even with testosterone. But I think the best response that we can have in your case, it's maybe 1 egg. So at least you will try. We can try with to do an embryo transfer, but the effectiveness of after 3 different cycles failed with no embryos to transfer, with different strategies, different doses, the best option is egg donation. Obviously, as egg donation, it's a change of mind. There are patients who prefer to try with all the options that they have before changing to egg donation. That depends a little bit on your if you are very tired of negative or bad results or not. If you can cope with more cycles with maybe bad results, then as you are 38, we can try. I will suggest you to try with a different strategy to see if we can have at least 1 egg, but knowing that maybe only 1 egg could be obtained. But if you are looking for the most effective treatment, it's for sure egg donation.
Makes perfect sense. Of course, thanks so much indeed for yet another question and answer, help with that. And there's a thank you from Lenka as well. Okay, let's have a look. Sylvie has another question. I'm 49. I guess my only option is donor embryo. What are my chances of a successful pregnancy?
Well, now yes, of course, with 49, we always do egg donation or double donation, depending on if the patient has a couple or not. But with egg donation, the chances of getting pregnant are around 60% at the first attempt. In the cases that we don't have a pregnancy in the first attempt and a patient needs a second cycle, 85% of patients get pregnant. And in the scare number of cases that need a third cycle with egg donation, 90% of patients get pregnant. So those are the chances of getting pregnant. Obviously, depends a little bit on if you have any basal pathology, on if you have any uterine malformation. But if everything is right, your chances are around 65% of chances of getting pregnant in the first attempt.
All right. Again, thank you for providing those statistics. I believe it, again, has been helpful for you, Sylvie. And yeah, I do believe so, as Sylvie has added. Thank you as well. Thanks indeed. Okay, let's have a look. I had early menopause at 46 due to high prolactin levels. Is it still possible to produce follicles by IVF?
No, if you have menopause, it's impossible. In those cases, even in younger patients with early menopause, the only option is to go through an egg donation. Yeah, if it's really a menopause, that means 1 year or more without your cycles.
All right, again, thank you for the clarification. And let's have a look. Christina has added another question here, a bit of a longer question as well. I am 41, have a lower ovarian reserve, 359 picomoles, have done a few IVF rounds when I was 40 and I have frozen 2 embryos. I have mostly done modified natural cycle with low stimulation. I was thinking to try a different protocol this time with deferlin and adding gonal-F as well as menopur. What do you think about this? I'd like to get to 1 or 2 more embryos before I proceed with the transfer.
Well, to accumulate embryos is an option that many patients want to try to have more options, because obviously if we have more embryos, because in fertility, there's also the good or bad luck factor. If you have more embryos, you have more chances of having one embryo that it can implant. It's a strategy that it can be successful in your case. I don't know why they have done in your case always modified natural cycles. Maybe because your ovarian reserve, I see your antimullerian level, it's in picomole. I have shown you numbers in nanograms, so it's your hormone, your antimullerian hormone, it's less than 1 in your case. So I don't know if even trying other strategies, only 1 egg can be achieved. But of course, you are 41 and you are not menopause, so we can try different strategies to see if instead of 1, 2 or 3 eggs can be retrieved, and maybe 2 embryos can be obtained and frozen instead of 1 in each cycle. It's a good strategy, gonal with menopur. Yeah.
All right, again, thank you so much. And let me go straight to Christina's question again, another one, okay? So I responded best on Clomid, but I already did 4 cycles with Clomid, and I heard that if it could increase cancer risk if used for repeated cycles.
No, don't worry. With 4 cycles, there's nothing cancer a risk increased cancer risk. But it's true that Clomid it's usually used for more mild stimulation. So in your case, I will suggest to stop with clomid stimulation and try with gonadotropins. I think it's the best treatment in your case.
All right. Again, thank you for another advice, of course, right here. Christina, I do believe that, again, it has been helpful, and there's a thank you from her as well, as you can see. There are like few questions left. So remember that if you have any else that you would like to ask, do it now. Type those in and let's have a look, okay, at the next one. Irene has added this. Is it possible to improve AMH levels naturally? I'm 33. I have a low AMH for my age. My partner's semen analysis is normal. I am wondering if I should go straight to IVF or still keep on trying. We've been trying for 2 years. Thanks.
Okay. Unfortunately, no, there's any kind of treatment that could improve MH levels, because that means that there's no treatment to improve ovarian reserve. There are some experimental therapies, but that have not been shown or proved yet to be used in the clinical practice. After 2 years of trying naturally without success, yes, I will suggest you to start with a medical treatment, because I don't know which is the level, but if it's really low and you try for 2 more years, it will decrease even more, and then maybe it will be late to do a treatment. So usually what the International Medical Association says is that when a patient is 45 or younger, after 1 year of trying without success, they should start with a treatment. And if the patient is older than 35, after 6 years, they should start with maybe not a treatment, but they should go to a doctor to start all the study to try to diagnose which is the cause for the infertility. So in your case, yes, I will suggest to start with a fertility treatment.
Yeah, of course. Thank you so much indeed for your question. And it's better to start working on that as soon as possible, then I guess, right? Thank you so much indeed. And of course, let's have a look. Another question is coming up. I'm 39 and I had 4 IVF with total of 11 embryos transferred, but there was no successful pregnancy. The quality of the eggs was not the best. I do have low AMH. Do you have any suggestions how to proceed? Would you recommend to do another cycle?
Well, maybe another, we can, obviously there's always the chance of doing another cycle, but to recommend another cycle, I will need more information about these previous cycles, because what we don't recommend is to do again the same after 4 failed cycles. So, or we can do something else to try to improve the results, or if there's nothing else that we can do, then we skip to egg donation. But if having the information about these previous cycles, if there's something that could improve the ovarian response or the ovarian quality, then I will suggest you are 39. You have chances of getting pregnant. So if there's something that can improve the response, I would suggest you to do another cycle with your own eggs. But again, I need more information about the previous cycles.
Again, thank you so much indeed for yet another question. And well, right now it might be our final question, but of course, if you have any left, you know what to do. Go ahead, type those in. We definitely want to use the time for all your questions. So of course, don't hesitate, okay? If not, we will be finishing. So do it now. Let's have a look at the question. So how do you determine the best medication?
The medication to use. Well, that depends on the ovarian reserve of the patient. That's how we determine the dose, and also the age of the patient, because depending on the age, we prefer to use some kind of gonadotropins or some other. And also it depends on when we do the ultrasound to do the antral follicle count. If we, for example, see that there are follicles of very different sizes, maybe we decide and if the patient has a low ovarian reserve, maybe we decide to start with pre-treatment with estrogens. So usually it depends on the age of the patient, the antral of the ovarian reserve, the experience of the doctor with each medication. That's important too. And the last and very important factor is if the patient has done previous cycles, because that gives us a lot of information to know if it's better to change the kind of gonadotropin or not.
So again, thank you so much for yet another question. And let's, yeah, there is one more question. So I guess we can go ahead with that. Irene, my IVF got cancelled due to MTX syndrome. What should I now? I'm 43. It was my first attempt.
Okay, it's different if she had an empty follicle syndrome because she had a low number of follicles growing and they weren't able to get or recover any egg from this one or two follicles or if she had a very good amount of follicles and no egg was recovered. But there are some strategies that that can improve or can try to avoid this empty follicle syndrome. And they is change the gonadotropin and use a dual trigger. It's what we do the trigger of the ovulation with two different medications, and we program the ovum pickup a little earlier than in the first attempt. So that's the strategies that we use when a patient has had an empty follicle syndrome. But it's not the same to have an empty follicle syndrome if a patient has a low ovarian response to the medication, or if it's after or if it's an unexpected empty follicle syndrome.
Thank you, Irene, of course, for yet another question. And again, Dr. Anna, for your thorough answer to this. Of course, there are different possibilities then, I guess. And Christina has one more question. So is it recommended to use Lutetium on repeated months to regulate my menstruation cycles? For a few months, my cycles have stopped and I have had to take Lutetium to regulate it.
Depending on if you want, what do you want? I mean, if it's to stimulate the ovaries, it won't be a substantial change achieving a regulation of the cycle before the stimulation. If it's to prepare your uterus, to prepare the endometrium before an embryo transfer, sometimes we need to regulate the cycle in order to have a good endometrium that can achieve a good thickness to receive the embryo. So depending on the treatment that you're going to do, if it's to do an IVF treatment, to start another stimulation. Okay, clear. So then we, at least here in Barcelona, we don't try to have regular cycles before. Once the patient is ready to start, we try to evaluate at which point of the cycle is she with a blood hormone test, and depending on what the result is, we tell her to start with stimulation, or we provoke her cycle to start up just afterwards. So in my opinion, there's no need of having 3 or 4 regular menses before starting the stimulation, because it won't improve the ovarian response.
Thank you, Dr. Anna. Christina, I do believe it has been helpful. Someone is typing, so let's give it a minute, okay?
Yeah.
Yes, there is the answer from Christina, actually. So again, someone is typing. Let's give it a second. I want to make sure that we have been able to answer all of your questions. But of course, as always, let me remind everyone that if you have more questions, we still have time tonight. But also, there is a possibility for you to get in touch with Dr. Anna and her team at Eugin. And I have no doubt they will be able to help you even with more details. And in the meantime, one more question is right here. So let's have a look. I have an AMH of 3.0 picomoles at 34. Would you recommend a stimulation treatment first before a natural modified treatment?
Yeah, we usually start the first treatment, the first strategy is to start with a stimulation treatment. Because maybe instead of one egg, that is what we are going to get with a natural modified treatment, maybe we will have 2 or 3. And when we talk about 2 or 3, one more, one less, it marks a difference. So yes, in your case, I will start at least at the first attempt with a high dose of stimulation. And if it doesn't work, then we always have the option of the natural modified cycle.
And that was again clear, I guess, as well. So thanks so much. And yeah, might have been our final question. But of course, if, as I mentioned, if you have more, you can get in touch with Dr. Anna, her team at Eugin. And thank you so much, Dr. Anna, for being with us, for providing all those cases, for explaining how it works, and of course, for answering all those questions. And I do believe it has been very useful for you. And well, thank you so much for joining us tonight, spending this Monday evening with us as well, and finding out a bit more on what can be done, what can you do to hopefully improve your chances. And of course, thank you well again. And also, before we finish, Dr. Anna, anything else you would like to add?
No, I want to say, as you have said, that if they want to know anything else, they can contact the clinic, and we will be, don't hesitate to contact the clinic if they want to even send a question to me through the clinic, and I will be able to answer, and we will try to answer all their questions.
Of course, as I mentioned, I'm sure that you will be able to help out. And this is, of course, a webinar. You can ask your question. And I do believe it's always good opportunity to get even like a second opinion in a way. But of course, you know, this consultation part is definitely important. Doctors need all the details, so don't hesitate. And of course, thank you so much for joining us. And remember, it has been recorded. You will have a chance to watch this again on myavifrances.com. It will be available tomorrow, and also on our YouTube channel. And if you go to our YouTube channel, you will see that there are exactly 398 webinars already, which is quite a lot, different topics. So I'm sure you can find it useful. You can look at different doctors, different opinions, different advice as well. So just check it out if you haven't seen it, of course, already. And thank you so much, everyone. Have a lovely evening. Dr. Anna, it's been a pleasure. Glad that you have joined this project with us, because of course Eugin has been part of the webinars with us, but of course this is your first with us. I'm glad that it happened, and I do hope that we will be able to cooperate some more in the nearest future. So have a lovely evening, everyone. Thank you for joining. Enjoy.
And
okay,
good evening.
Thank you so much.
Bye bye.
Bye.